Hello everyone, welcome to the online medical imaging class. My name is LIN. I'm a radiologist from the second affiliated hospital of Central University Medical College, China. I'm the course director for this online medical imaging. In this session, we are going to go through the normal manifestations of gastrointestinal imaging and their typical disease. Upon completion of this session, I hope you can be able to describe basic pathological changes, niche, and filling defect. Identify the imaging features for typical GI tract disease, such as small bowel obstruction, perforation, esophageal carcinoma, achalasia, esophageal varices, benign and malignant gastric ulcer, and chronic adenocarcinoma. I would like to start with a question. Which imaging modality would you use for those who have progressive dysphagia? There are four choices. Which one is true? Plain radiography, CT scan, MRI, or Barren swallow? Yes, Barren swallow is the correct answer. Progressive dysphagia is suggestive of esophageal problem. Esophagus is a hollow tube. Without external contrast, it's very hard to see the mucosal changes. And Barren swallow is a useful and the first examination to assess the morphologic and motility of the GI complaint. As the patient tests the Barren suspension, digestive tract is outlined by the opaque Barren. This enables the hollow structure to be imaged. Regarding the Barren swallow, I will let you know more in a couple minutes. I had to emphasize that Barren swallow is not the only imaging modality to be used to evaluate the GI tract problem. Like X-ray, CT, MRI still can be helpful in some specific clinical conditions. Let's have a look first. This is a 5-year-old boy complaint of dysphagia and pain. Chest X-ray, combination of PA view and lateral view demonstrate a foreign body in the upper esophagus. Here is a typical case of the GI tract perforation confirmed by the erect abdominal radiograph. The image on your left is normal, and the right one shows free air under both hemidiaphragms. Plain abdominal X-ray is also the preferred initial examination to evaluate the bowel gas pattern. The left one is normal. The case on the right shows air fluid levels and dilatation of the small intestine. So this is very typical imaging of small bowel obstruction. CT is sensitive and highly accurate for the diagnosis of severe grade of small bowel obstruction. Here, adhesion and the narrowing of the distal bowel can be accurately assessed by CT scan. The small bowel obstruction is the result of an incarcerated right linguinal hernia confirmed by CT scan. MRI provides good soft tissue contrast. This is a case of rectal carcinoma on MRI. Irregular wall thickening can be easily seen. Besides, the serosal is clearly visible. So far, I have just discussed some of the imaging modalities for GI tract disease. Let's say more about Barren examination, which is the main content of this section. Barren examination continues to be the primary radiologic modality for evaluating the structural and functional abnormalities of GI tract. Fluoroscopy from several projections, real-time X-ray can be obtained while the patient drinks liquid Barren. Though it is not as sensitive as endoscopy, but it is more readily available. Spicuous case can be referred onto endoscopy for further confirmation. In the following time, you will learn how to recognize the normal manifestations and some of the most common abnormalities of the GI tract from the esophagus to the colon based on Barren exam. This is the mucosal phases and filling phase of a normal esophagus. the mucosa has a smooth, normal thin, pale layer and uniform appearance. The filling phase shows a smooth appearance with indentations from aortic knob, and the left main bronchus and the left atrium, which should not be mistaken as abnormal complexions. The filling phase on the left case shows a circumferential irregular distal narrowing in the lower esophagus caused by a carcinoma. In the middle, a smooth, tapered distal esophageal narrowing is depicted, typical for achalasia. The case on the right demonstrates mucosal thickening, enlargement, and blunting as a result of intensive esophageal varices. This is the filling phase and mucosal phase of a normal stomach. The gastric mucosal folds are depicted as tubular, slightly undulating, and radiolution filling defect on the top right. Do you think they look like a project field? Here is a case of benign gastric ulcer. In on fast view, looking at the lesion from the front on the left, an overbearing collection in the dependent part can be seen, with smooth fold radiating to the edge of the ulcer crater. In profile view, looking at the lesion from the side on the right, an over-projecting in the laser curvature can be found. This is the penetration of the ulcer projecting beyond the normal barium-filled gastric lumen. We can call it a niche in radiograph. What is niche? Niche means a recess in the wall. It refers to a persistent correction of contrast that projects outward from the contrast-filled lumen. These three imaging from barium exam, endoscopy, and graphic presentation together can help you better understand this point, I think. Here is a malignant gastric ulcer. Profile view on the left shows an intraluminal ulcer with irregular and nodular thickened mass surrounding the ulcer. On fast view on the right shows that the shape of the barium collection is not regular, with irregular thickened folds radiating to the mass. The left image shows a diffuse irregular narrowing and rigidity of the stomach. Linitis praestica can be diagnosed. The one on the right shows a lobulated filling defect in the greater curvature. Polypoid carcinoma is the final diagnosis by endoscopy. So, what is filling defect? A filling defect refers to displacement of contrast media by a space-occupying lesion in a radiographic study. A lesion, usually of soft tissue density, protrudes into the lumen and displaces intraluminal contrast. For example, a polyp is a filling defect. Again, these three images from barium exam, endoscopy, and gastric presentation together can help you better understand this concept. Duodenum forms a C-shaped loop around the pancreas. It can be divided into 4 parts. The first part is the mobile, with less mucosal fold, and gives an appearance of a duodenal bulb or an X-ray, like this on the left. The rest of the duodenum is covered by thickened circular fold. The arrow on the right shows the duodenal papilla, where bile and pancreatic ducts open into. Don't mistake it as an abnormal filling defect. The mucosa of the small bowel is characterized by thickened circular fold, which start from the second part of the duodenum. We also can call them vertebral mucosal fold. Pretty similar, right? Bovine animals are used to examine the large intestine. For this test, barium is introduced gradually into the colon through a rectal tube. As the barium travels proximately, it fills the colon, which shows up clearly on the X-ray, allowing us to see growth or polyps and areas of narrowing. Here are the filling phase and mucosal phase of a normal large intestine. their mucosal fold can be interpreted as chronic hausture. And these are two cases with descending chronic carcinoma. Bearing menimer in filling phase shows irregular narrowing and rigidity of the lumen. This is a typical case of chronic diverticulum, appearing as a multiple round and overbearing projections. Unlike an ulcer, the mucosa of a diverticulum is intact. Finally, I would like to use this graph to sum up the basic abnormalities of the GI tract lesions with Barron Mills. They are niche and filling defect. That's all for this session, and thank you for your attention.